Imagine your loved one collapses on the ground. You call 911 and you start CPR. The paramedics arrive and rush into the hospital, and you stay behind the ambulance all the way there. But when you get there, they ask you to wait in the waiting room. Seconds feel like minutes. Minutes feel like hours. And the fear of the unknown and behind the closed door suspicions is making everything worse. Hi, my name is Brent Bowen. I'm an ER nurse, and I'm going to talk to you about the barriers and benefits of family presence during resuscitation, and how the creation of an FPDR hospital policy can increase the psychological outcomes of patient family members and decrease the overall prevalence of PTSD in our community. I'm going to talk about how there are perceived barriers by healthcare professionals, what research says about these barriers, and how we can implement FPDR as a hospital policy. Since the first creation of closed chest compressions in the early 1960s, it has been the general practice of healthcare professionals to keep the family separate from the patient. According to the American Association of Critical Care Nurses, despite clinical practice guidelines and evidence-based practice, only 5% of hospitals in the United States have written policies for family presence during resuscitation. Sadly, this has become the status quo due to these perceived barriers by ER personnel. The first barrier I'm going to talk about is the distress in family. In 2013, Jabra et al. Did a study of 570 patient family members in France. Half of them were allowed to be with their loved one during CPR, and the other half were not allowed to be with their loved one during resuscitation procedures. Once the study was over, it was found that the group that was not allowed in the room had a higher prevalence of symptoms of PTSD, anxiety, and depression at 90 days after they were present for the resuscitation procedure. The next perceived barrier is distress in healthcare professionals. In 2012, researchers Letterman and Watt did a survey of 100 ER healthcare professionals in the Yale New Haven Hospital. The results showed that 77% of healthcare professionals were in favor for family presence during resuscitation. This still shows that there's a discretionary gap between the decision of allowing the family to be present and not allowing them to be present. Without a set hospital policy in place, it really just boils down to who's working that day on whether they get to be present. And that's not really fair patient care. The next barrier I'm going to talk about is the fear of family procedural interference. During this Jabra study, it lasted 20 months, 570 patient family members, less than 1% of this study had any aggressiveness towards staff or trying to interfere with any type of resuscitation procedures. Now that I talked about the barriers and benefits of FPDR, I'm going to talk about the process of implementing it as a hospital policy and the importance of educational initiatives. Fernandez et al. Did an investigation of ER healthcare professional opinions and experiences with having family present during resuscitation. It was found that the majority of ER healthcare professionals are in favor for having the family present, but that there would be a higher prevalence of support for this if there was a set hospital policy in place. ENA practice guidelines, which is the Emergency Nurses Association, states that there should be set policies for each institution for caring for the family while their loved one is undergoing CPR. As far as hospital policy, the first component that would be required is educational modules provided to the ER nurses. This would be on how to communicate with the family and how to interact with the family member while in the code room. The next component would be the creation of a family presence facilitator role. This would be an allocated member of the healthcare team that's not involved in the resuscitation procedures, who would teach the family member about what they're about to witness, what treatments are going to be used. They will be responsible for chaperoning the family member through the code room, debriefing them, and this family presence facilitator would also be responsible for being the communication liaison between the code team and the family of the patient. Porter et al. Did a study of 17 resuscitation procedures in Australia. Some of the procedures had a family presence coordinator, and some of them didn't. It was found that the resuscitation events that didn't have a family presence facilitator role, communication was confusing and ambiguous, and they found that communication was improved when there is a communication liaison personnel involved. There should be a family presence facilitator and a family presence during resuscitation policy implemented to increase the psychological outcomes of patient family members, in addition to bridging the communication gap between ER personnel and patient family members. We talked about how this can decrease PTSD in patient family members and how there's a low chance for family procedural interference. In addition, there is a large majority of healthcare providers that accept and would be willing to practice the event of having family present at the bedside. We also talked about how hospital policy would be implemented and how educational initiatives are important. Things such as educational modules on FPDR for nurses and the creation of the family presence facilitator role. I'm calling for this facility to create an FPDR policy, not only for the psychological improvements of our patient families, but for the improved health of our community as a whole.